Thank you very much. I know most of you. Hi, how you doing? So, this is going to be a really, really informal session just about talking about public health and talking about how, as midwives, we bring it into every conversation we have with women. So, and sometimes you perhaps don't realise you're talking about public health, but you are. It's not a new thing. It's been around a long time. So it's going to be really informal. I hope we'll get some little tips for you, and I'm happy to answer any questions at the end. Okay. So I'm going to bring it right back to the history of it. So, like I said, it's not a new thing. 175 years this has been going on that we've recognised the importance of public health. And actually, the first Public Health Act was actually passed in 1848. So that's 175 years ago. So I've picked out the key bits which are relevant to us as midwives and as healthcare professionals working with mums. So in 1874, the Birth, Deaths and Registration Act came out. And then in 1903, it was the first time they'd recognised that we need to provide some antenatal education for working class women. That's what they said, the mothering skills, they called it, for working class women. And then also for school inspections, for medical inspections for children in school. So they're starting to realise the importance of actually nurturing these children and making sure that their health and well-being is looked after. And also then looking at free school meals as well. So looking at feeding our children, like I said, building them up. Then in 1918, we had the Maternity and Child Welfare Act, and this actually was the first one that supported the health of pregnant and nursing mothers and children under the age of 5. So I said it's been around a long time. Also in the same year, which I thought was really interesting, was in 1918, we had a pandemic. So COVID wasn't the first pandemic. We had Spanish flu. And I found a little picture. Thank goodness the masks have moved forward, because look at that. Can you imagine wearing those? Imagine wearing these big duck-billed masks around. But it just shows that actually, even back then, they were thinking about stopping the spread of a infection or a virus by wearing a mask. So there were some pictures of just people wearing masks over their noses, and I thought, well, that's a bit ridiculous, isn't it? They're still talking and breathing, so it probably wouldn't have stopped any spread. So then in 1921, we had the Mary Stopes opens its first sexual health clinic. So again, this is pinnacle times where we're thinking about sexual health, women's health, and actually women's rights as well. And then in 1928, as we all know, penicillin was discovered. And this was groundbreaking at this point. This is a real key public health time. However, it wasn't actually, we didn't use it till 1946. But it was around in 1928, so we knew it was a couple of years before we actually could use it. And then in 1948, our lovely NHS. That we absolutely love, and it's continued to grow over the years. Then go back through to contraception. 1961, the first oral contraceptive pill. Again, this is groundbreaking for women's rights as well. This gave women choice about their reproductive choice, gave them choice to kind of have some sort of fertility control. So it's really great stuff. And then we looked at the first cervical screening service. It was in 1964. So these don't seem that far away, really, do they? But actually, these are key moments. Then in 1967, we had the Abortion Act and the Family Planning Act. And they were the Family Planning Act enabled other contraceptive methods to be used. So this is great for women and their choice. What's that?
The Americans just take a...
Yeah, I know. I focused on Britain for this one. So then in the 80s, we're going into the 1980s and 90s then, we have the epidemic, the HIV and AIDS epidemic, and we knew what happened with that, completely blew up. The media took control of this as well. This was a lot of scaremongering went on there. Again, we now think very differently about this to what we did then in the 80s and 90s. Then we had the flu outbreak. So that came then in the 90s and 2000s. And then we had the National Chlamydia Screening Programme in 2002. So only in 2006 we had the Health Act. Honestly, it's so close. It makes me feel really old if I think 2006 wasn't that long ago, was it? It's like 16 years ago. So it's not long. Then we look at the HPV vaccine introduced for girls. So we making sure now we have that for boys. So they did it for girls in 2008. And then 2010, the Marmot Review came out. Now, this was predominantly for England. However, this is a key document because the Marmot Review looked at tackling health inequalities. And these are the things that we talk about really, really widely now and trying to reduce that health inequality for women and their families. So that was stemmed from the Marmot Review. Then in 2012, again, key to maternity, pertussis. the whooping cough vaccine was introduced for pregnant women. And again, this just seems to be a normal embedded thing now, doesn't it? Women go and have their whooping cough vaccine. Then only in 2019, abortion was decriminalised in Northern Ireland. That was only a few years ago. So women they used to come over the border to Liverpool to have any abortion care, but now they can have that over in Northern Ireland as well. So again, it's increasing the rights for women. Yeah.
I can remember seeing women coming to us.
Yeah, and they do. They come over. I know. So we're still in the southern. It's the southern. It's a bit different, I think, as well, isn't it? But in Northern Ireland, it was decriminalised. So then I've only brought this up to the pandemic because we all know what's happened since then. So the pandemic then, the World Health Organization declared another pandemic in 2020. And how all of our lives changed in that pandemic, how the way we look at public health has changed, our use of face masks, our use of social distancing, all that came in. And as midwives, our practice changed and we adapted. We turned virtual pretty much overnight. Telemedicine was a thing that we'd never really done before. So we still had to deliver those key public health messages in a different way. And boy, did we adapt to it. We really did. Everyone should be really proud of themselves about how they coped in that pandemic, because it was really difficult times. But actually, what we're seeing is that the outside of that now is that the health hasn't suffered. Maybe continuity has suffered, with lots of kind of staffing issues, but actually the health of women, we've still really had that drive to push that public health messages. So I'm now going to go on to, I just thought it was a brief little history of public health, because not a lot of people kind of really know much about that. So I'm going to now talk about the myths. So as midwives, I'm pretty sure you could all write a book on this. So we need to debunk these myths. So has anyone got any examples of any kind of old wives' tales they may have heard about public health that women have said to you or that you've heard that maybe aren't so true now? Anyone got any examples?
Salt baths after you've had the baby.
Oh, salt baths, right. Okay. Yes, to help with the perineum. So the healing of the perineum. Yeah.
Take with a pinch of salt.
Yes, absolutely. So yeah, you're right. So it's just, and this may have come from a grandmother or may have come from an auntie, and it's like kind of these old wives' tales they embed down into their families. Absolutely. So a couple that I found when I was trawling the internet was about heartburn. Oh, the baby's got a full head of hair. If you've got heartburn, we know there is no evidence base behind this at all. But women still continue to say it. So it's about, and they will cut, even on Monday I was running a clinic and a woman said to me, I've got terrible heartburn. Oh, this baby's going to be full head of hair. Actually, so our job as midwives is to say, actually, may not be the case, and just trying to be in a very kind of nice way, but to get the correct public health message out there. So we then talked about her diet. Actually, we found that, before bed she was eating a lot of chocolate. That's what was causing the heartburn and the gastric reflux, not the baby having a full head of hair. So it's just about kind of just talking to women, and it's those everyday conversations, and they drop these little nuggets in. So it's about how we deal with that as midwives. So the next one then is stretching. Apparently if you stretch your arms above your head, it'll harm the baby. So again, I remember my mum telling me this. Now we know that if you've got a surge of relaxing, you're more likely to pull a muscle. We know that. But certainly stretching and Pilates and yoga is very good for pregnancy. So we would advocate it. So lots of women, we don't want women walking around like with their arms down, too afraid to stretch. So the next one then is eating for two. You're pregnant, you need to eat for two. So I hear this a lot through my healthy pregnancy clinic about eating for two. It's not about that as well. So it's about, again, explaining to women that it's actually increase your calories by about 200 calories per day towards the end in your third trimester if your BMI is normal, is within normal ranges. Otherwise, they don't need to increase it. So, and 200 calories is a banana. So let's put it into context. It's not eating 2 meals because you're pregnant. The next thing is spicy food. Spicy food will induce labour. No, it doesn't. It doesn't at all. This is an absolute myth. And actually it's explained to women, they might eat lots of hot curries towards their end of their pregnancy to try and get labour started, or drink castor oil. Have you heard of all these other things? Again, we're trying to discourage women to say, actually, there's a myth. There's no truth in this, or it's not evidence-based. Now this one actually got me. I did never heard of this one before. Pregnant women are not allowed to step over rope. So apparently, if they step over rope, this tangles the cord. So, I know. So I was like, wow, I've not heard that one before. So yeah, absolutely no evidence base whatsoever. Babies move in pregnancy, they move, and their cords do get wrapped around them. That's fine. So the next one is excessive rubbing of their tummy. So rubbing of the tummy can harm the baby and can spoil the baby, I think was one of the myths. Don't spoil your baby by rubbing your tummy. Now, we encourage women to talk to their tummy, to touch their bump. We encourage that. This is all part of the bonding process. So, yes, certainly not, don't discourage the rubbing of a tummy. Obviously, really excessive rubbing is probably not a good thing, but, actually just touching your bump and talking to your baby is perfect. Cravings, what your cravings mean. Now, lots of people will say, oh, if you're eating sweet stuff, what are you going to have? A girl. If you're eating salty, you're going to have a boy. Yeah, no evidence base whatsoever. There's nothing. So actually, it's your cravings are based on your hormone surges from the placenta. It's based on you might crave different things at different times in the pregnancy. So next one, if you drink a glass of milk, that will produce more breast milk. Wow. So we know milk's derived from blood. It is not actually milk's very good for a pregnant woman because of the calcium in it, but actually, it's not going to increase your breast milk. So anyway, they were just a couple of things that I wanted to kind of talk about. And again, to see how public health is brought into every conversation we have, and that women will always talk about these conversations. They'll have conversations with, maybe cashiers in the supermarket. There'll always be somebody giving an opinion about public health bits. So we know as midwives, we're key health professionals to provide that public health message. Public health protects and enhances the health and social well-being of women to make healthy lifestyles. That's what we want them to do. And it's a great opportunity in pregnancy. Women are motivated to change. So if you're ever going to change a woman or change behaviour, pregnancy is the key time to do it because they are really on board with health changes. So I said pregnancy motivates women to achieve optimal health, and it's at a time that they're receptive to improve their health as well. So that's why, Healthy Pregnancy Clinic, when we talk about water birth, we're talking about weight gain in pregnancy, and the ultimate goal is to achieve that water birth. Women are motivated to do it. They really want to. So public health messages shouldn't be seen as additional work. This isn't seen as a separate topic. This is embedded into everything we do in midwifery. At any stage in the pregnancy, there's an opportunity for public health messages. There is some key documents, and that's the Step in Public Health. That's an RCM document, and that was actually written by Billy Hunter and Julia Sanders and Lucy Warren, and they looked at actually the public health, what messages midwives give, and there are some topics actually we're very good at talking about, and others that we're not so much. So the ultimate aims, I have to talk about the aims of public health because there's a reason why we do it. So our aim is to reduce health inequalities, to protect against disease and infection, to have improvement initiatives such as stop smoking and weight reduction, and then to look at making sure our healthcare is effective and efficient and it's accessible to all. So when we talk about public health, I'm sorry, I'm racing through these now. This is everything that encompasses public health. So we have every woman that comes through our path would have something to do with, we'd have some conversations around these messages. Things like sexual health are really important. Health inequalities, tackling those health inequalities, making sure women have access to care. And I'm going to talk about a little bit more about that in the next slide. Perinatal mental health, making sure we're asking those questions, those Hooley and Gadd questions that are in our maternity notes, making sure we're asking to say, are you well? Do you feel that, are you getting overwhelmed? Are you having feelings of anxiety? Making sure that we're understanding that their mental health is well. Contraception, I'm going to go into that a little bit later because I could talk about that for a month. But yeah, postnatal contraception is really, really important. Again, protected characteristics as well. So making sure that we are supporting women with additional needs, such as autism, such as maybe if they're homeless. And actually, we're not talking about healthy eating and cooking with somebody that's homeless, when actually they don't know when they're going to get their next meal from. So is it appropriate then to talk about kind of, what they should be making for food? Things like cervical skin, I'm not going to go through every single one of these, but they're really, really important key bits of public health. And they start from the booking interview right the way through to postnatal. Okay, and it's our job as midwives to tackle every single one of these. And like I said about the stepping up for the RCM, that RCM document I was talking about, they actually, the team that wrote that document actually said that midwives are really, really good at talking about things like the perinatal mental health, things like the bereavement, maybe smoking, infections, stillbirth, exercise in pregnancy, healthy eating. They're really good at talking about that. The bits that they're not so much good at talking about is maybe asylum help, or like I said, homelessness maybe, or communicable diseases. So if a woman is tested positive for syphilis, maybe midwives are not as good as talking about those difficult conversations than the more routine everyday ones. Okay, so it's about really being in touch with every single one. And the VALE-B is the violence against women and domestic abuse and sexual violence. And it's making sure that we're in touch with that we are up to date with that, and that we can actually provide evidence-based information to women and support for them. I'm going to click onto the next one. So I just want to look at this missing voices. So when we look at our Embrace report, and the Birth Partner Project gave a fantastic session, just at the last session, about supporting women who are seeking sanctuary and that have no support. And these are the voices we need to support, because we know that they are more likely to die during childbirth if they are from an ethnic background or from global majority backgrounds. So it's really important that we don't call them hard to reach groups. They're not hard to reach, we just don't try hard enough. So it's really important that we actually get through to these groups and support them, and use groups like the Birth Partner Project to help us gain access to build this trust. We know that, and it's quite a sobering read, we know that if you're from an Afro-Caribbean background and you live in the most deprived area, you are an increased chance, or the highest chance, of a stillbirth. So how do we tackle this inequality or this issue? And it's about simple things. Women who have difficulty in travelling, maybe have no means to travel to a hospital, group their appointments together. Don't give them 4 appointments in 1 week to get to on different days. If they need a glucose tolerance test and they need a serial scan, do it on the same day. And at that point then, an antenatal check as well. So that woman is not constantly trying to find the means to travel to a hospital appointment, because they disengage. They will not engage. They've got, or if you've got a woman that's has a chaotic life, has perhaps 9 children, is really struggling to actually get them to school, to get them everywhere, don't then put an appointment at 9 o'clock in the morning for her. So it's just thinking outside the box, making it easy for them to access care or take the service to them. We work with the Birth Partner Project, but prior to working with the Birth Partner Project, we set up, myself and Wendy Ansell, who is the specialist midwife for women seeking sanctuary and survivors of harmful practices. We set up a session called Women's Hour, and it's totally taken from Radio 4's Women's Hour, but we thought we were going to call it Women's Hour. And we went into the hotels. And the hotels are where we had the Afghan women seeking asylum. The families were based in the hotel. Now, they had no means of transport, but they were all in the one big hotel. It actually was in the Copthorne, not far from here. So they were all in the hotel with their families, and we were invited to speak. So, we thought it was an opportunity. So we were invited by them to actually talk about being a woman and what services we offer. So we used one of the conference rooms. We thought this is a really good opportunity here to deliver public health messages. So we used one of the conference rooms, and we basically had a drop-in. So we could have had 5 women turn up, or we could have had 18. It was whoever wanted to come. We had the health visitor as well. And what we did is one of the women that were living in the hotels spoke 3 different languages. So we were able to sit there and we were able to talk about sexual health, being a woman, contraception, about birth spacing, the importance of birth spacing for future health, the importance of actually preconceptional care starts day 1 postnatally. So we're able to talk about this in 3 different languages. So we would say one thing and then it would be translated 3 different times. And that experience was the most humbling ever, because we were able to really engage with these women. They all told their stories, a lot of them of how they'd got to, how they'd arrived in Cardiff. A lot of them had gone through the trauma that they had gone through to get to this point. They'd been up against kind of war-torn countries, and it was really hard hitting. But knowing that we could offer that support to them, and Wendy was amazing. She came with all their prescriptions, so it was like Call the Midwife days really. But it was an opportunity, and it's taking those opportunities when they present, because they can present at any time. So after we'd done our session, we were there about 3 hours in the end. We were then invited to eat with them. So we then met their partners, their husbands, their children. We met all of them. We met every single person that was in that hotel, and we were able to just be that presence. That actually we are there to help you. We're there to offer advice, and this is the key for public health information. It's slotting it in at every opportunity. Make every contact count. It should never be ignored. Let women lead conversations, and then you've got an opportunity as a health professional to deliver that message. So, like I said, it's midwives need to promote family-centred care, but in meaningful conversations. We don't want to stand there and just say, right, you need to do this, 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 and this. Or you say, you need to not put on any more than 5 kilos in weight in pregnancy, and then just show them to the door. That's not meaningful, is it? It's actually just really root through the weeds. You need to get in there and understand these women, and actually understand every woman is different. Every birthing person is different. How can we help them and support them to make healthy lifestyle choices? So targeting key public health areas will empower women not only to make healthy choices, but it will reduce health inequalities as well. So it is going to make a difference to things like stillbirth rates. If we're talking about fetal movements and talking about patterns, and we've had that built up that relationship with women, it is going to actually help reduce the stillbirth rate. It's going to help women engage with care. That's what we want them to do, engage with us. We're there for them. And then it will reduce future morbidity and mortality in children as well. And that's it for me. Any questions?